there's two things we're using SDOH data for right now in two different ways within our population health work. And then there's another way that we're moving with what's the, when you ask what's the technology that's coming that we're interested in. So we use SDOH factors. We have a high risk underserved clinic that really manages these very high risk, high SDOH substance use and mental health, as well as medical complexity. For our value clinics in general, we have the ability to risk weight the panels by morbidity. When we looked at that clinic, we really had a difficulty in weighting the panels by just morbidity because it underweighted the complexity of what they were seeing because it didn't take into consideration the SDOH burden that these patients had. So we were able to use SDOH data, geocoding, and socioeconomic, CMS socioeconomic variability to develop a way to risk weight on SDOH for those providers' panels within that high-risk group, so that we could give them credit for the complexity the SDOH brought to those patient panels, and not create, have expectations for a panel size that, quite frankly, would burn out our providers and had historically caused burnout for those providers. We also, on the flip side of that, we have a population health management dashboard that we've put forward, and we can look at area deprivation index, socioeconomic index on populations, but we can also drill down to the specific domains that we're asking patients on, such as social isolation. And one of the areas we found this to be helpful is if we're the west side of our of Corewell Health encompasses a good chunk of the west side of the state of Michigan. So there's Grand Rapids, which is a fairly metro area, but if you go outside of Grand Rapids, it becomes rural very quickly, rural and agrarian. And when we look at COPD as a condition, we find that it's much more prevalent in our rural areas than it is in our urban areas. When we look at the outcomes of COPD, and when we look at that condition compared to others, we see that they have much higher social isolation. And so we're starting to figure out that we need to address that condition and mitigate it and come up with strategies to address it, because it's driving a lot of our poor outcomes with COPD and with ED utilization and other things. And that's where you're starting to get to actual plans based on the data, because you're connecting that SDOH data to specific populations, specific providers or practices, but also specific conditions. And then you're able to slice it by what are the outcomes that they're having within those conditions for ED per 1,000 or inpatient per 1,000, and do they have worse or better outcomes based on different factors. So